over the next 25 minutes, what my goal, and my name is Dr. Jessica Kirkwood, by the way, what my goal is to try to teach you an office-based induction of buprenorphine naloxone using the PEER guideline as my guide. So, as I said, my name is Jessica Kirkwood. I'm a family doctor out of Edmonton, Alberta. I work at a place called the Boyle McCauley Health Center. I do not have any industry funding to disclose. I do some teaching on particularly opiate use disorder treatment and the use of buprenorphine naloxone in your practice. I do that with the Alberta College of Family Physicians, and I occasionally receive honoraria from them, but otherwise I have no industry sponsor. So today's objectives at the end of the session, what I would like you to leave with, and we're trying to keep it in a short time frame, and so there are lots of places to get this information in a larger, more lengthy time frame, but I want to discuss initiating a patient on buprenorphine naloxone and then providing ongoing care and support for that patient. So the pictures I'm going to be referring to are what are found on the one-pager that came with the PEER guideline. This first algorithm deals a lot more with what we talked about in the series we just recorded. And so that's looking that if you have a patient with probable OUD and you may want to use something like the POMI or the Prescription Opioid Misuse Index to identify these patients within your practice, moving ahead and offering them either methadone or buprenorphine naloxone. From this point forward, I'm probably going to refer to it as Suboxone because that's the more recognizable term. Making sure that you know that both of these options are available for patients and both of these options have good evidence behind them, as we discussed in our last presentation. If psychosocial supports are available, absolutely those can be beneficial to your patients, and I recommend discussing those. But if they're not available or your patient isn't ready to engage in counseling or to take that kind of treatment, that's okay. Making sure that you still want to continue with opioid agonist treatment, as both methadone and Suboxone have really good numbers for benefiting these patients. So just a really quick note on what is Suboxone. The reason its name is so long is because it's two medications combined in one. Buprenorphine is a partial opioid agonist with a high affinity for the mu receptor, and naloxone is an opioid antagonist. There's a bit of misconceptions in terms of what that naloxone's doing there. I've heard all kinds of things from both the medical community and patients, but really naloxone is present to deter IV misuse. So if patients crush and inject the medication, then theoretically the naloxone is the component that works and they go into opioid withdrawal. I've absolutely had patients tell me, hey, Dr. Kirkwood, I injected that Suboxone you gave me and it didn't do what you said it was going to do. And so then I say, okay, well, are you going to do that again? Are you going to continue to inject it? And they're like, well, no, probably not. It didn't really do very much. And I think I'll just take it under the tongue. So, that's probably a good idea. Let's go ahead with that. Yeah, as I mentioned, it's sublingual tablet. In generic form, it is in 2 dosing strengths, and you usually just refer to the first number in that, which is the amount of buprenorphine in the tab, so a 2 milligram tab, an 8 milligram tab. In trade, there is a 16 milligram tab. And there are some differences between generic and trade in terms of the taste of the medication, how quickly it dissolves. And so if your patient is having any sort of issues with whatever form they're on, making sure that you look into what are their coverage options for the other form, or is that something that they would benefit from and maybe they would help them with their treatment. Most common adverse events, this is an opioid, so you're going to see nausea, you're going to see constipation. I see patients complain of sweating, and just like many drugs we use, there's a long list of side effects, but I find it's generally well tolerated. Onset of action takes about 30 to 60 minutes, and you're going to have a peak effect in 1 to 4 hours. At a patient's stable dose, this medication can work for about 2 to 3 days, and so the nice thing about that is patients can miss a dose, or if there's any issues, and it doesn't affect them to the degree that some other medication options might. What I say to my patients is your stable dose is when you feel good from today's dose past tomorrow's dose. So oftentimes, substance use disorders have a ton of stigma. These patients, again, are told that they're bad people doing bad things. And so there's a misconception that they need to suffer their way through sobriety or that this should be uncomfortable. And I spend a lot of my time actually encouraging patients to increase their dose so that their dose is lasting them through because they don't need to suffer. Oftentimes our patients have been exposed to enough trauma in their lives. I say, you've suffered enough and let's just get you comfortable. I'd like to take a minute to just talk a little bit about an antagonist versus an agonist, a full agonist versus a partial agonist versus an antagonist, because sometimes that concept can be confusing, and it's an important thing to kind of get a grasp on so that you understand why starting Suboxone has a bit of a trick to it. And so when we're talking about a full agonist, I have methadone on the slide, but that could certainly be morphine or fentanyl or heroin or anything that activates the mu receptor fully. Let's think of a fast car going 180 kilometers per hour. When we're talking about a partial agonist, such as buprenorphine, that's a slower car traveling at 50 kilometers per hour, and naloxone would be a rock, not moving at all. So if you're flying down the highway at 180 kilometers per hour and you drop a rock on the hood of your fast car, that's gonna feel really awful, and that's gonna put you into immediate withdrawal. And so that's what happens when somebody is experiencing an opioid overdose and they're given naloxone. Oftentimes, they don't wake up feeling great. But if you were traveling at 180 kilometers per hour and you slowed to 50 kilometers per hour, that still wouldn't feel very good. You're still going to experience a degree of discomfort. And so that's where that concept of precipitated withdrawal comes from, in that if you have a full agonist on board and you introduce a partial agonist, that partial agonist is going to displace the full agonist, and then it's only going to fill the receptor halfway. And so that is putting you into withdrawal. And I mentioned it in the last video, it's really not something you want to do to a patient who's already struggling with withdrawal. They don't like the way opioid withdrawal feels. I think that we really sometimes can underestimate how bad withdrawal feels, and we don't know the degree of psychological trauma that is also associated with withdrawal. So it's not just that somebody gets sweaty and they have the chills and they feel like they have the flu. There's a massive psychological component to that. And so to have our intended treatment cause that, it's not preferred, and it's something that can be easily avoidable if you just go about the right way of starting. I will say that this car analogy, it's not my own. I had first heard it from Dr. Christy Sutherland, who works out of the downtown east side in Vancouver, and I found it's been a really great way of explaining these concepts. So that precipitated withdrawal, what is it? Again, because buprenorphine has a high affinity for the receptor, it's going to displace what has, it's going to displace anything else, and then it's going to make people feel sick because it's not activating the receptor fully. So in order to avoid this, there's a few different things that need to happen. And this is in a traditional induction. So if you speak to people that are really familiar with the med, there's lots of different things that are being tried out there. And there's ways to get people on Suboxone that don't involve them having to go into withdrawal. And if you have a patient who says, I would do all this, I would totally go on this med, but I don't want to go on withdrawal, that's okay. Phone a friend, talk to a specialist colleague, and there's ways that you can get them on the medication without doing this. This way, it just works faster. It gets people stabilized quicker, and it really can be very easy to do as long as you feel comfortable being able to assess how much withdrawal they're in. Ways to do that are by telling them to not use or take an opioid for a certain amount of time. And we said about 12 to 24 hours. If a patient says to me, there's no way I could go 12 hours without using, that's okay. I just want them to come to me when they're in withdrawal. And then we can use something called a clinical opioid withdrawal scale to assess how much withdrawal they're in. And I'm just going to flip to the next slide, because this is what one version of that looks like. If I go to the following slide, you'll just see up in the top right corner, that's how Peer's version of the COWS score is going to appear on that one pager. So going back to this, you'll see that there's some subjective things, there's some objective things. And sometimes there's this misconception that, well, this will take a really long time. I'll have to see the patient and do this big assessment and decide. And I just argue that if anyone is literate and verbal in your office, they can perform this. So it doesn't necessarily need to take away from your busy schedule, your medical office assistant, your nurse. If you're sending the patient directly to the pharmacy, your pharmacist can certainly complete this with you. And then all you want to know is, okay, they presented to my office, and what is their COWS score? And so just to go back to the previous slide, the number that we want is greater than 12. It's just moderate. And if I leave it up to patients, I find that they're actually much meaner to themselves than I would ever be, and they come in very, very sick. But really, it's just moderate withdrawal. And then the last way that we try to avoid this precipitated withdrawal from happening is by providing a low initial dose. So coming along to this algorithm, which again, you're going to find in the guideline, starting at the top, you get your patient and they should be in opiate withdrawal with a COWS score of greater than 12. At that point, you're able to give them 4 milligrams or 2 2-milligram tabs of Suboxone that they take under their tongue. And you say, I'd like to see you, or contact you or reassess you in 1 hour. And so again, people have this thought, well, if I have to give them a med and they have to wait an hour and then I get another assessment, like, oh, I just don't have time for this. I'm really, really busy. I can't fit this into my day. Okay, but we have resources that can help us with this, and it really doesn't need to be that long. That follow-up in an hour could be that they bring a book and they wait in your waiting room and you say, okay, it's been an hour. Let's see how you're doing. It could be a phone call. It could be that they then go to the pharmacy in an hour to see the pharmacist. Really, at that 1 hour checkpoint, all we're trying to determine is, has that bad thing happened? Have we caused precipitated withdrawal? So we're asking, do they feel significantly worse? And I'll tell you, I've only ever had 2 patients that I've put into precipitated withdrawal, and both of them definitely told me that that bad thing happened. There was no, maybe it is, maybe it isn't. It is very clear if a patient has this sudden effect. And again, I think I should just, again, only 2 patients. That doesn't mean I'm really great. In fact, when I do a lot of my workshops and I talk to other frequent prescribers of Suboxone, I was actually, for the longest time, I had the highest number of people. So I was starting to question myself if maybe I shouldn't be the one giving the talk. But this isn't something that happens frequently, I think, because we know and we have a way to do this properly. That being said, I will often see patients that will say, I'll never try that Suboxone. I took it once and it made me so sick. And that's where I have to take a step back and explain to them that if they purchased Suboxone and took it because they thought it was an opioid like any other, what happened to them, and reassure them that that won't happen if they follow along with my induction. So at that 60 mark, do they feel way, way, way worse? Darn, that bad thing happened. And at that point in time, you have a few things you can go over. I really like that Pierre decided to put this non-opioid withdrawal management table right there on this one-pager. I think it is so helpful because you have all these different meds, and really, when you're talking to somebody about their withdrawal, it can be felt in a lot of different ways, whether it's GI discomfort or anxiety or sweating or whatever, and the table lists different options for you that are very safe to use. I also will sometimes give my patients a little kind of take-home kit that will help them get into withdrawal, and it could include these medications. So if there's somebody that says to me, Doc, there's no way that I could get in enough withdrawal to start, I said, well, what if I gave you some other options to tide you over? And they're quite open to that, and it works very well. If that precipitated withdrawal thing happens, first manage their symptoms like you would if anybody presented with opioid withdrawal. And then you need to decide what you want to do. Do you want to move forward and continue trying the induction? Your patient may say, that is enough for me today. And they might decide that they're going to go home and sleep it off and try again tomorrow. And that is okay. It is also definitely okay that depending on the resources you have in your community, that you pick up the phone and call someone. Say, uh-oh, I just tried to start somebody. They went into precipitated. What's my next step? Again, not something that happens frequently, but something that's important to know. More likely what's going to happen is your patient is going to say, I feel fine. Can I continue? And that's great. And now you're rolling. So moving forward, you can give them a second dose of 4 milligrams and then give them another 4 milligram dose to take later in the day. I would not encourage having this patient wait around and stay in your office for a whole day so that you see them take everything. In fact, I don't encourage that you have a pharmacist be forced to stand and observe them take this medication. At that point, as long as you've assessed your patient and they're not in precipitated withdrawal, by all means send them home with the other 8 milligrams, because 12 milligrams is our kind of max for the day on day 1. If this patient's in a setting where they can be observed more closely, you can absolutely go higher than that. And there's lots of different ways to do a Suboxone induction, but this way seemed the most clear. And usually by the end of the day, the patient may not say, this is great, I feel 100%, this is my dose that I'm gonna be on forever. But you've convinced them they feel better than they did when they started the day, and they're wanting to continue on. When we were making this algorithm, when you're talking to people that maybe aren't as evidence-based as the peer team is, and well, I do it this way and I do it that way. And initially when I would present, I would try to say, there's lots of ways you can do this. And I found that most family docs got pretty mad at me. And they said, give me something just specific and straightforward. And that's what I love about this is if you have never prescribed this medication and you're really hesitant to, you can follow this along. It is easy to interpret and you can do an induction without worrying about maybe 2, maybe 4, or whatever dose you might use. If they feel fantastic on 4 milligrams, by all means, they can stop at 4 milligrams or 8 milligrams. But when I see patients, again, I may not see exactly the same as your practice. A lot of my patients are using illicitly and a lot are using IV. And so I have very few patients that at 4 milligrams or 8 milligrams say they're feeling well. I get a frequent question at my seminars about, well, what if somebody's just buying T4s or T3s? Would this be an option for them? And it absolutely is. And I definitely see those patients stabilize out on a lower dose. And again, that stable dose is just my dose today lasted me through my dose tomorrow. Moving on to subsequent days, it just gets more simple. So on day 2, they can have 16 milligrams as a total dose. On day 3, they can have 20. And on day 4, they can have 24 milligrams. And that means that in 4 days, you can have somebody on the max dose of this medication, and typically they can feel really comfy. In Pierre's Clinical Pearls, they mention this, and I always do when I'm talking about inductions. If someone's on 24 and they're still having cravings and withdrawal, you can absolutely go above 24. If this is your very first time, I'd pick up the phone a friend, but that friend is probably going to tell you, yeah, why not try increasing? Maybe go to 28 and see how they feel. If they're experiencing side effects, you may want to pause at some point, but I don't typically see that. And again, it can be really difficult to determine, well, what is actually opiate withdrawal versus side effects from the med. If you don't feel comfortable going to 24 on day 4, that's okay too. You can have somebody get to 12 milligrams on day 1, give them a week at 16 milligrams, and then have them follow up in your office. And that's a perfectly reasonable approach, particularly if you're new to prescribing. I think the main message that it's just important to get out is this medication is not difficult to use. It is not scary to use. It is not any more harmful than some of the other things we prescribe. And it's really effective and works well in this patient population. And so it should be something that you have in your repertoire. And in any of the training sessions I've done, when docs come back and say, hey, I've started prescribing since your talk, and well, how's it going? They say, yeah, it's really not that hard. And they've helped a lot of people with it. Take-home inductions are something that I think we should consider, and something that I use more in my practice now, because it can be pretty difficult to tell a patient, we'll show up at 9:15 with a Cal score of 13, and if you're 5 minutes late, well, I don't have time to see you then, or whatever it might be. I think that a lot of times these patients are maybe not your most reliable patient that's always there, and so we need to be a bit more flexible. I'll often just say to my patient, show up in withdrawal, and we'll fit you in and we'll assess you. And this type of fit in is a brief one, but if they don't think they can come in withdrawal, but they think maybe they'd rather go home, that's totally fine. I'm going to give them a full 12 milligrams for their day 1 that they take home as a carry, and then they're going to use something called the subjective opiate withdrawal scale. And that is a way for them to just assess. It doesn't have those objective kind of like vital sign type things. They can just assess when they hit it's 17 or above that they're able to go ahead and start. And they can start on that medication at home, and then the following day they can go to the pharmacy. This is also a great option for patients that don't have access to a pharmacy that's close to them. And you're basically educating them just like you would with anything else that they need to be in withdrawal to start. And it would be nice if they could call a provider. Most clinics offer on-call services, and this would be a good use for it, just to say, even if they were feeling hesitant, that they could call and say, okay, I think I'm ready to start. This is how I feel. Go ahead. So your goal dose is going to be about 16 to 24 milligrams. You can go up and down by that, or by 4 milligrams per day, depending on how people are feeling. I would say see the patient weekly until they're stable. You're going to realize that they stabilize pretty quickly, and then you can move on from there. It's kind of funny because often if you're dealing with a patient that has been coming because they just need an increase in their meds, or they've lost their meds again, or whatever it might be, you're actually seeing them quite frequently, and then it's sort of like, where did she go? Like, I used to see her all the time, and now she's really not around very more. If they do have ongoing, as I mentioned, if they have ongoing cravings and withdrawal and they're at that 24 mark, you can certainly go above that. And as I say, you can call a colleague if you need to be able to feel comfortable doing that. Ongoing care really isn't that tricky either. When you're seeing them, you're finding out, is their dose adequate? Are they having any side effects? How is their ongoing substance use? And I like to draw attention to this because, so let's say you start somebody on Suboxone and they say, yeah, things are going great, excuse me, but I'm still using a bit of cocaine, or I'm still using a bit of crystal meth, or whatever. That's okay. And I think we need to be okay with that, and we need to make sure that they know that we're okay with that, because I'm treating your opiate use disorder. I'm not treating your other substance use issues with this medication. A lot of times my patients' other substance use improves when their life stabilizes, but that may not be the case. And that's all right, because they're safer on this medication than they would be on others or accessing an illicit supply. Are they having ongoing cravings? This is where I'll see patients, they'll say, yeah, my dose wears off about 4 hours before, but it's okay, like I tough it out, I get through. And I'm saying, why are you toughing it out and getting through when you can be more comfortable? When it comes to sleep, patients will often say they're sleeping a lot better because maybe they were having to use through the night because they were feeling so sick. But also a lot of my patients, particularly in corrections, will experience what's called using dreams. And those are really, really vivid, almost PTSD-like dreams of using or seeking, and they'll wake up just in a sweat, really upset, and they'll think, oh, is this a side effect of the med, or why is this happening? And I just try to provide support in that it's just their brain hasn't caught up with what's going on. Can you imagine if in 4 days they've gone from this horrific cycle of use and withdrawal to all of a sudden feeling comfortable for 24 hours? Well, their brain's not ready for that yet, and that's okay. Just reassuring and providing supports. And if there's psychosocial supports, absolutely. Do you want somebody to talk about? But making sure that we're not saying that this is a side effect of the med or a reason we would want to stop the med. In fact, that gets much better with time. And overall, looking at psychosocial functioning, how are things going? It's interesting because in the peer guidelines, some of the counseling studies that we looked at were basically that. And it was a 15-minute visit, really just focusing on these few light things. And that showed a really big improvement. So that may not even just be, that may just be their visit with their provider. It's not counseling necessarily. It's that they're having this interaction with a person and discussing how things are going in their life. And that improved their retention and treatment. A few questions that we didn't get a chance to really address in the last talk. So hopefully if you're here, this is helping answer some questions for you. I always get asked about benzodiazepines because, as we know, combining an opioid and a benzo is not a good thing. If you look in the middle there, it's usually equates to about a 6 times increase in overdose death. But when you put a patient on OAT, that risk lowers at about 2 times. And so that's another reason why if a patient's on benzos, prescribed or illicit, it shouldn't be a reason to withhold their access to OAT. In fact, it should be a reason to encourage it. Other special considerations, pregnancy, acute pain or injury, so somebody breaks their leg and ends up in hospital, if they have an elective surgery planned up, or they end up in hospital for some other reason, or incarceration, the bottom line in any of these situations is don't stop their OAT for any of these circumstances. I'm not going to be able to get into all of the details behind that, but I think there's a lot of misconceptions out there that if a pregnant lady's on Suboxone, she has to get switched to something else. That is not the case. Pregnant patients do very well on Suboxone, as do their babies. Same thing if somebody has pain, that their pain cannot be managed if they're on Suboxone. If you look at like the overall concept, the risk to taking them off of these meds comes back to those numbers that we looked at if we're looking at tapering or withdrawal management alone. And that's these patients are at a high risk of an overdose death. And we need to be very cautious whenever we look at a situation where we look at taking them off of their meds and really question if that's necessary. And that comes to tapering. Patients will present and they'll want to come off their meds. Involuntary tapering, meaning I say you have to come off of your Suboxone for a reason. I don't have really any good ones. Absolutely safety at the end of the day would be it. But again, being on this medication is far safer than accessing something illicitly. So I say risk versus benefits, but I really question that. The voluntary patient-driven taper is more what I see as a patient coming in saying, I've been on this for 10 years or I've been on this for 10 days. When do I get to come off of it? And really, more often than not, I'm trying to convince them that maybe now is not the time, particularly if they haven't made big changes in their life, and particularly if we're looking at shorter time frames. It takes a really long time to develop opiate use disorder and get to the point where you're going to need this type of management. So why should we expect that we're going to cure somebody in weeks or months or even years? Definitely you want to maximize their chance of success. So people do have a poor prognosis if they're using other substances. Pregnancy is not a stable time in anyone's life. It wasn't in mine. So that's not really where we're going to want to make a big change in meds. If their physical or mental health is not at a good place, again, not the time to do it. And remind them that it may take a year or longer to successfully complete cessation. We looked at that observational study in the last talk that over 10 years, over 25,000 patients, that was looking at methadone, but only 2.5% were able to taper off. Some people may look at that number and think of it as a failure, and And I think we just need to change the way we think, because how often when you diagnose a diabetic patient, do you say that like, and you know what, we're going to get you off of these meds one day. In fact, we have a discussion about down the road, we may need to increase the amount of meds you're on or do more. And we're not punishing them, and we're not saying that they're failing if that's the case. That is the nature of this illness. And it's the nature of opiate use disorder as well. I just really, really strongly think that we need to change the way we look at this, and we need to realize that this is a chronic, life-threatening condition, and it should be managed as such. And thank you so much for your time. I hope this was helpful. Again, if there's lots of other places to get this information, and there's ones that do it over a longer time frame, and I encourage you to access things, but most importantly, I encourage you to look at incorporating these treatments into your practice and helping your patients. Thank you very much.